And thanks to Eric and the crew at Enhanced Medical Nutrition for the opportunity to share this presentation with you, which I've entitled Nutritional Support for Surgery, Preparing for the Fight and then Recovering Afterwards. My small confessional is that I'm an exercise person by training, but I look at things from a biochemical perspective. But really my interest in supporting surgical patients has grown out of the fact that I view surgery much like an athletic event. In other words, that it's a tremendous stress on your body and that it makes little sense to not prepare for that event, both from a nutritional standpoint and if you like, and if you had the opportunity from a training standpoint. So viewed from that standpoint, that's where I'm coming from this evening. These are the funding sources that support the work that we do and some disclosures that I need to make. I'll just give you this sort of vernacular here around prehabilitation and rehabilitation and give you my language and the way that I view things here. So from a prehabilitation standpoint, if there were a clinician or a therapist talking to a patient, it would be to prepare someone to withstand the rigors of traumatic event or surgery in this case. Whereas if I were a coach or talking to an athlete, I would say that prehabilitation is essentially a form of training. We're getting ready to perform. And then rehabilitation, it would really be the action of, in this case, restoring someone to health or normal life through training and therapy, whereas the clinician or the therapist talking to the athlete would say, this is returning to play if they were injured. So it's really some cross-cultural definitions where we're talking about a stressful event in the case of surgery or in the case of an athletic event being something that you obviously prepare for. And so that's the context in which I'm couching all of the paradigms that I'm going to discuss here. So when we talk about prehabilitation, this is the training or the preparation for the stressful event or the catabolic crisis and immobility, if you like, that is associated with the surgery, and then the rehab, which is the recovery. And this is a model that Franco Carli has sort of immortalized in terms of preparing a person for surgery is really trying to elevate their functional status or the functional status of the tissue that's going to undergo the stress so that we realize that there's going to be a decline in function and probably a decline in the quantity of the tissue as a result of that stressful event, in this case surgery, but the functional recovery is going to occur quicker and maybe even lead to somebody coming back stronger than they were prior to the surgery. Whereas if there's no prehabilitation, as you can see here, the individual would not have the opportunity to recover, would experience a sharper decline and a deeper valley and take longer to recover. And possibly in the situation with surgery, be exposed to greater stresses in the recovery period that might result in readmission or revision. This is a great quote I like to borrow from Dave Evans. He says that surgery is much like a sport, and I couldn't agree more. And he said, you know, we have to be trainers. If we're not well trained and you're not ready for surgery, then you're not going to do well. So from that context, it's really a nutritional preparation that I'm going to talk about. So to prepare for the stressful event, what we need to do is, if we can, is to train. I mean, obviously, physical therapy prior to the event would set a person up for a more rapid recovery. At the same time, if I were to tell an athlete to get ready for a stressful event, it would be fully hydrated and to fuel appropriately. And the fuel that powers any athletic event, and much like trying to withstand stress, is carbohydrate. And so I know that some of the carbohydrate pre-feeds resemble, in terms of their composition, very similarly isotonic sports beverages, for example. And then we're talking about preparing the musculoskeletal unit to withstand stress. And that's where protein comes in. And that's what I'm going to talk to you or spend the majority of my time discussing with you this evening. There may be some surgery-specific goals, of course, in maximizing or optimizing blood sugar regulation, as well as medication optimization, which probably don't concern the athlete too much. In the post-surgical suite, then, we're really talking about recovering, and it's a simple strategy for athletes, and it's the same for patients. It's the 3 R's. We need to focus on rehydration, we need to focus on refueling or restoring carbohydrate into the system, and where I'm going to focus on is the repair and restoration of the damage, and to allow the healing process in this case to return, and that's going to require protein. So from the standpoint then of protein, and the analogy that I'm going to use is one of a brick wall. So the musculoskeletal unit, which would include any connective tissue as well as the muscle itself, is really a wall made up of bricks, which in this case are amino acids. And interestingly enough, these types of walls in our body, the tissues are undergoing persistent and ongoing turnover, or if you like, there are bricks being added to the wall and bricks being taken out. And in doing so, then you have an optimally, or hopefully optimally functioning brick wall. The schematic representation looks then something like this, and it's the processes of bricks going into the wall, which we're going to talk about as muscle protein synthesis, and bricks coming out of the wall, which we're going to talk about in the framework of muscle protein breakdown. So that when somebody consumes protein, you get a big stimulation of protein synthesis, you get a suppression of protein breakdown, and we get an accretion of tissue that's transient in this situation until you find that somebody eats their next meal. And so we get an area of accretion followed by a small area of loss, and then we get another area of accretion, and then another area of accretion following. So this would be our breakfast, lunch, and dinner time meals. The situation's a little bit different than when somebody either loads their muscle due to activity, because all of these periods then are amplified in terms of their effect. And the result is true even in the fasted state, is that you're losing less amino acids. So in this situation, you can envision that the tissue itself would be healing faster or regaining some of its structure afterwards. And that's a function then of loading and as well of the amount of protein that these people are consuming. There are two things that oppose this process, this normal fluctuation in protein synthesis and breakdown. The first one is aging, and the second one is disuse. So when you think about the case of orthopedic surgery, and the ages of your patients are probably in their 60s and beyond, you can expect that coming into the surgery, they're not in a situation of full, robust stimulation of protein synthesis, but something that's more like this. So this patient would be much more difficult to have them recover without consuming sufficient quantities of protein throughout the day, and emphasizing high quality protein as well. And I'll explain what that means a little bit later. The point I want to make here is that an older patient coming in is probably already under the throes of sarcopenia. They're losing muscle mass as a result of their age already, and simply the catabolic event, that's the stress, represents a decline that older people find it difficult to recover from without appropriate countermeasures that in this case would include obviously rehabilitation, but the nutritional support of high quality protein, such as the products that are provided through enhanced medical nutrition. So this sets up a so-called vicious cycle where older people, as a result of bed rest and joint replacement or illness, go through periods of inactivity. They experience declines in muscle protein synthesis. They lose muscle, recovery is impaired, and you can see that this is a downward spiral. Of course, what we would enjoy is to have these patients consume more protein in the post-surgical period, prepare themselves for surgery prior, and then more optimally recover in the phase afterwards. So the question becomes one of, can you overcome this anabolic resistance of both aging and disuse? And the simple answer is you can. This is a figure showing a study in which patients were exposed to 28 days of bed rest, and one group received an amino acid supplement, and you can see they're the experimental group versus the control group, and this is the change in their leg lean mass. So this is their muscle mass within excuse me, their legs during a 28-day bed rest period. And in the control group, you see exactly what we would expect, this disuse-mediated loss of muscle mass, and yet supplementation with high-quality amino acids and protein is able to offset that. The interesting part, too, is that there is a functional benefit that's associated with this as well. So it's not simply a reduction in the loss of mass, but you can see here there's a greater preservation of strength. Now, everybody declines, and that's what you would expect in a situation of muscle disuse, but the group that is supplemented for 28 days experiences a smaller decline. This is their voluntary single repetition leg extension strength, and you can see it goes down a lot less. The interesting point here is that maybe it doesn't require all of the essential amino acids that are present in high quality proteins, but there's one amino acid in particular that's important, and that's this amino acid here, and that's leucine. Leucine, if you remember, is one of the 3 branch chain amino acids, and in this experiment, again, it's a short-term bed rest model in middle-aged adults, and you can see that there was one group supplemented with leucine here that experienced a smaller decline both in their whole body lean mass, but importantly in their leg lean mass. And the same sort of result in terms of muscular performance was achieved. In other words, the group that supplemented with leucine were able to generate more force than the group that was in the control condition. So short-term bed rest induced atrophy and loss of tissue and function can be offset with leucine-rich protein supplementation. The active amino acid then is leucine. This is a branch chain amino acid, one of the 3 that's, if you recall from your biochemistry, isoleucine and valine are the other 2. And this stimulates a canonical signaling pathway within the muscle, as well as other tissues, to stimulate protein synthesis. And we now have a very good idea of how this works. It's through a very complex molecular mechanism. But I'm going to show you some data that hopefully convinces you that this is the key and critical amino acid. So the protein type clearly matters, and the devil, as is often the case, is in the details. So quite simply, not all proteins are created equal. And this figure is to highlight that the leucine content of certain proteins, and I'm showing you whey protein isolate and whey protein concentrate here. These are the proteins that come from milk, as opposed to soy protein isolates. This is a concentrate from pea protein. This is a concentrate from rice protein, and this is a collagen protein. Now, all of these sources of protein would appear on the label of a product as protein per se, but you would have to look to the list of ingredients to find out that whey protein, and if you look at this figure right here, it shows you that you would have to consume twice as much of these proteins or 4 times as much of this protein to get to the amount of leucine that is present in the whey protein isolate. Now, what does that mean? Quite simply, you're getting a suboptimal dose. You can see here with soy and rice protein that is only able to be overcome or compensated for when you ingest almost twice the amount here. So you can see that you can make up for a dose of whey protein, which is really optimal at 25 grams here, by consuming more, but it requires almost twice as much of this. And these are protein isolates, remember, these are not foods. Quite simply, the result is that you get less of a stimulation of protein synthesis. And this is work that a former graduate student of mine, Nick Bird, now a professor at the University of Illinois, did in older men, showing that other proteins that are present in milk, and in this case it's casein, or the curd fraction of milk, or what you might see on ingredient labels is caseinate. And so caseinate is the open bars here, and the whey protein then is in the black bars. And you can see quite simply that feeding these older individuals whey protein was far more effective at turning on protein synthesis. And even in a situation where we added exercise, the whey protein was much more effective. Quite simply, whey protein sits at the top of the heap with respect to the proteins that stimulate this anabolic process. So the take-home points I want you to walk away from here are that a catabolic crisis like surgery can be prepared for to improve outcomes. The declines in protein synthesis determine changes in muscle mass, and specifically the atrophy that we see in disuse situations. Aging and disuse induce anabolic resistance in skeletal muscle and possibly other tissues, so connective tissues such as ligaments or tendons, and maybe even in bone as well. But this can be overcome with the consumption of high quality protein supplementation. And by that, I mean proteins that are high in leucine, and you can offset some of this disuse-induced atrophy. Leucine is the key amino acid, and really what we're talking about in terms of recommendations are to train for surgery, to try and get ready for the fight. So supplementation pre-surgery is definitely recommended. Prehabilitative exercise would be optimal as well. We would like to introduce rehabilitation or movement as soon as possible. Even minimal amounts will work, and then people have even used neuromuscular electrical stimulation, range of motion exercises, and to try and time the protein feeding for post-contraction or post-rehab session, which is much akin to timing the consumption of protein following a bout of exercise, for example, to take advantage of the effect that exercise has. To feed high quality whey protein containing a high leucine content, and this would be done daily at regular intervals, then the dose that we figured out to be optimal is around 25 grams per feed. I'd like to thank you very much for taking the time. I know it was a brief run through there, and I'm hoping that if you enjoyed the presentation and if you do have any questions, I'd be happy to try and answer them for you.